Fab.
Okay, right, I think we're recording. Okay, cool. Welcome everyone. So this is the first Paramedics Zoom of the year, the academic year. Tonight we've got Lauren Greasley presenting general surgery quiz for finals. It's just a crash course really of general surgery. So without further ado, I'll hand over to you, Lauren.
Hi, thanks Abby. So as I say, I'm Lauren, a current 5th year, and this talk is mainly about the key concepts in general surgery, and it's going to be mainly a quiz format with some little bits of knowledge along the way. If you've got any questions or anything, just give me a shout, and my email address is at the end, okay? So initially when I'm revising, this is just how I like to revise, by breaking topics down. So in terms of general surgery, you've got esophageal pathologies like GORD, esophageal cancer, tears and motility disorders. In terms of the stomach, you've got conditions like hernias, peptic ulcers, gastric cancer, hematemesis presentation might come under that. In terms of hepatobiliary and pancreatic, you might think about jaundice, cholecystitis, cholangitis, cholangiocarcinoma. It's good to get these pathologies in your head really, because their names can be quite confusing. But also you've got sort of liver pathologies like cysts, abscesses and cancer, pancreatitis, and not forgetting the spleen. The spleen can have infarcts and also rupture and injuries. For the small bowel, you need to be thinking like infections and gastroenteritis, tumours, and different conditions like angiodysplasia. Sort of covering the large bowel as well, you've got appendicitis, diverticular disease, Crohn's and UC, volvulus obstruction. You've got many conditions there. Presentations wise, you've also got obstructions, perforation and Molina. And in terms of anorectal conditions, you've got hemorrhoids, cancer, sinuses, fistula, abscesses, fissures, prolapse, and various conditions there. I'm not going to cover breast pathologies today, just in the interest of time, but I'll try and cover the following. A good part to revise is just the abdomen and the acute abdomen. So making sure you know the 9 areas of the abdomen, and the surface anatomy, and it really helps when you're coming up with differentials. The dotted line at the top here is the diaphragm, and just because it's not always taught, this the first horizontal line you've got is the subcostal plane. It's sometimes called the transpyloric plane, and that's around the L3 vertebra. And the second line across, you've got the transtubicular plane, which is around L5. While you're revising as well, I'm not going to go through it because it's quite easy to look up, but make sure you know your surgical scars, such as your midline and paramedian and things like that. While discussing the acute abdomen, you've obviously got various pathologies like small bowel obstruction and various things like that, but make sure you don't forget medical causes of the acute abdomen, such as endocrine disorders like Addison's, diabetes, pheochromocytoma. And then also you've got infective causes of the acute abdomen like TB, a basal pneumonia and things like that. Okay, so let's get into some questions. So the first question is, a 70-year-old female has a 1-week history of left iliac fossa pain associated with diarrhea. Her temperature is slightly raised and she's
Sorry, I don't know if the slides moved on.
Okay,
sorry.
No worries.
Yeah, that's it, perfect.
Okay. So, as I say, we've got a 70-year-old female, 1-week history of left iliac fossa pain with diarrhea. She's got a mildly raised temperature and she's tachycardic. Any ideas what the presentation might be? I'll give you a second to think about it. Okay, so For the first point, appendicitis, it's unlikely to be that because usually you've got your classic central abdominal pain around the umbilicus migrating to the right iliac fossa. So that rules appendicitis out. In terms of a Crohn's disease presentation, this lady's quite old for a new Crohn's diagnosis. It's unlikely to have a slightly raised temperature in Crohn's, not impossible, but unlikely. And you probably would want a longer history with Crohn's unless it's an acute flare. The actual answer is diverticulitis. You've got this lady's the right age for this, and it's also in the right area. Most diverticulitis flare-ups are in the left iliac fossa. Sometimes in the right iliac fossa, you can have Meckel's diverticulum, but that's just a side note. It's quite important to try and get these classic case presentations in your head. So what age is the patient? How long's the history of the pain and things like that into your head. For a gastroenteritis case, yes, they will have a temperature. They might be a bit tachycardic, but the history might be a bit more acute, and you might get a bit more description of the diarrhea, and maybe, you know, history of eating warmed up takeaway rice, things like that. These sorts of things gives you clues. Also remember that in questions, they have to, whatever information they put down, it has to be relevant. Okay. Does that all sort of make sense? Any questions? Okay. So which of the following signs are signs of appendicitis? Okay.
I don't think it's moved on again, sorry.
Sorry, it must be being really slow. Is this moving, Abby?
No, it's not. I don't mind if you want to send me it, and I don't mind sharing it. Or yeah, we've moved on. That's fine. It's yeah. It's
take it
on.
off presenting. Okay. So what are which of the following are signs of appendicitis?
You don't want the rice?
No,
Either.
that's fine. That's fine.
Okay, so just going through them. Robsing's sign is a sign of appendicitis. It basically is palpation in the left iliac fossa causing pain in the right iliac fossa. Sower's sign is also a sign of appendicitis, which is right iliac fossa pain when the right hip is extended. Obturator sign, again, is another sign of appendicitis. When the patient's knee is sort of flexed at a right angle, as you slowly internally rotate the hip, that causes pain for the patient. McBurney's sign is just something I've made up. What the revision point I wanted was just to highlight where McBurney's point is. So it's just that you draw an imaginary line between the umbilicus and the ACIS, and it's a third of the way from the ACIS. Murphy's sign is not a sign of appendicitis. That is a sign of cholecystitis. It's basically where you put your hand at the base of the right subcostal area and the patient has pain on inspiration. Okay, moving on. We've got a 45-year-old male who has a history of back pain, and they're complaining of epigastric pain, and they're passing black tarry stools. Pain is relieved by eating. So which of these might the patient be suffering with? Feel free to shout if you've got an answer or a question. So going through each of the answers, gastric ulcer, in a classic presentation or classic case in medical school exams, gastric ulcers are identified as the patient tends to have pain after eating, unlike being relieved by eating. So it's unlikely to be that. A ruptured AAA is the presentation's usually quite central abdominal pain. In the question, the patient tends to be hypertensive and quite unwell. 3, the liver abscess, well, the liver is in the right upper quadrant, so it's unlikely to be that. And the actual answer is the duodenal ulcer. Again, this is classic presentation where pain is relieved by eating, and epigastric pain. Just on that note, this patient is obviously presenting with Molina. Does anyone know how you would manage Molina, or how you would investigate and what you should do? So in terms of managing any patient in any sort of exam scenario, you always want to say that you would do a thorough A to E assessment and go through that, their airway, breathing, circulation, etc. It'd be important to do a set of observations and check they're not hypertensive and there's not a serious bleed somewhere. Then once the patient's stable, you want to do a history. It'd be very important to do a good examination, including abdominal and a PR, because it'd be important to know if the patient actually has Molina on the digital rectal exam. If you're not sure, Molina is this black tarry stool that's quite slimy in nature and does have a quite offensive smell. And then with any sort of management plan, you need to describe what you do, for example, in an OSCE. So you do some bedside tests. So like we've talked about, observations. If indicated, you might want to do a urine dip if they've got some dysuria. This is a really bad management plan because I've just wrote bloods. I've not wrote what kind of bloods. So we obviously want to do a full blood count, check in particularly for a low hemoglobin. Also using these LFTs, the usual, but particular importance paying to urea. As with any patient with abdominal pain, you also want to make sure you've got a lactate because that can indicate how unwell they are. Okay, so moving on, we've got a 60-year-old female who's presented with dysphagia and lethargy. And on examination, she's got glossitis and pale conjunctiva. So glossitis, if you're not sure, is basically quite a large tongue that's quite smooth. So I'll let you have a moment to think about that. Has anyone got any ideas?
I think, is it number 1?
It is, yeah, well done, Abby. So the Plummer-Vinson syndrome, so this is literally this presentation of dysphagia and lethargy. So they have this large smooth tongue or glossitis, and they are anemic. Okay, just to explain, a Mallory-Weiss tear is basically a tear of the esophageal mucosa, and the presentation is usually someone who's a chronic vomiter or is using alcohol in excess and has been vomiting. Boerhaave syndrome, sorry if I'm not saying it right, is an esophageal rupture, and I just remember that by Boerhaave begins with B, so it's a big rupture. Okay, next question. So which of the following is a risk factor associated with gastric mold lymphoma? So we've got nitrosamines, H. pylori infection, a rubber factory worker, or a high diet in oxalate. Okay. Has anyone got any ideas? Don't worry if not. So the actual answer is a H. pylori infection. H. pylori has quite a good association with this particular kind of cancer, but there is a loose association with other kinds of gastric cancer. For our learning, nitrosamines, this is associated with esophageal cancer. People who have exposure to rubber, that is a risk factor for transitional cell carcinoma of the bladder, and patients who have a high diet in oxalate, which is things like beer, beans, chocolate and coffee, all the nice things basically, they are at an increased risk of renal stones. Okay. Oh, sorry, so this is one of those annoying exam questions where there's a bit of reading to do. So you've got a 52-year-old male who's got 3 weeks of fatigue.
Oh, I don't think we can hear you, Lauren. Lauren?
His ALT is slightly raised, ALP is significantly high, bilirubin is again minimally raised, and his gamma GT is raised. He has an ultrasound abdo exam, ultrasound abdo, and it shows bile ducts thickening and dilatation. So just as a revision about LFTs, this is in the context of this is talking about jaundice, whether it's pre-hepatic, hepatic or post-hepatic, but I just want you to look at the bloods. So I just remember that ALT is hepatic has a T in and ALT has a T in. So I remember if that's really high, it's something to do with the hepatocyte in general, whereas ALP is more to do with sort of a cholestatic picture, so something after the liver itself. So back to the question, what the question asks is, what is the most appropriate next diagnostic investigation? So this is one of those questions where it's really important to read the question. So you want the diagnostic investigation, not necessarily the ultimate treatment. So you've got CT abdo, an ERCP, a liver biopsy, an MRCP, or a percutaneous transhepatic cholangiography. Has anyone got any ideas what the answer might be here? So for the most appropriate next diagnostic investigation, you've got this MR, so magnetic resonance cholangiopancreatography, and basically it shows a beaded section in the bile duct. And the reason the actual, this is sort of a two-part, one of those two-part questions where annoyingly they don't want the diagnosis of primary sclerosing cholangitis, which you might know is associated with UC and things like that, and it shows it in the LFTs point towards this diagnosis, but annoyingly it wants the diagnostic investigation. So you need to be aware with questions such as this. Moving on. Our next question is a 65-year-old male. He's got abdominal distension and is vomiting 48 hours after a sigmoid colectomy. Now he's not passed any flatus for the past 24 hours. He's on regular paracetamol and he's also had some PRN morphine. His abdomen is distended and he's got tenderness over his wound. Which of the following treatments do you think is most needed? Okay, so just going through them, the actual answer is an NG tube. So any patient that's got some sort of paralytic ileus, which this patient has, or anything like an obstruction or anything like this, you want to do the drip suck technique. So where you put an NG tube down and basically investigate further. And also ultimately make the patient nil by mouth. It's not number 2, it's not an emergency laparotomy, because basically I just remember that surgeons don't like operating unless they know what's happening, if possible. So you want to do some more investigation, really. An enema is unlikely to help in this scenario. You could probably try it, but they're not even passing gas. There's probably a significant pathology here. And another option potentially people might do is some more pain relief, some more IV morphine. But as you know, that may make the situation a lot worse with the constipation. I've not told you the observations in this question, just as a point that if you're not told the observations, you might assume that they're normal. So in which case the temperature's normal. Therefore, there's no indication of giving these IV antibiotics. PIP, TAZ is piperacillin and tazocin. Okay. The next little section I want to go through is abdominal x-rays. This is sort of the last bits to this talk. Has anyone got any questions or anything so far? Okay. So this is a normal abdo x-ray, and I quite like to go through an x-ray systematically. So it's important to check the details of the patient, the time, have they had any previous x-rays of the abdomen, and also you want to know the clinical context of why they're having it done. And then it's also important to know the exposure, so it's important to try and see the diaphragm and also see the whole pelvis. And then I have the mnemonic BBC, so bowels and organs, bones, and then calcifications. So in terms of the bowels, you should see the large intestine forming a frame around the circumference of the abdominal x-ray. The small bowel tends to be central. It's not always very visible, but that's fine. As you can see, the spinous processes coming down here, and you'll have a quick look at the bones and of the ribs if they're visible, and the pelvis, and checking the femur. And also you can then look at the bladder, and if you can see any renal pathology. On this note, you might want to look for any calcifications. So can you see any renal stones or anything in the ureters, which you can't? Okay, so moving on to abnormal x-rays. These both show the same pathology. Just a spot diagnosis. If you're not sure, that's fine. But if you are, do you want to shout up? Okay, so what both of these show is basically you can see these lines going across, and they are the valvulae conniventes, and they're almost forming like a coiled spring, and they're, as you can see, it's quite central in both images. This is a classic sort of small bowel obstruction picture. Another sort of teaching point here is that the small bowel should be no larger than 3 centimeters in diameter, and you'll have to take my word for it, but it is greater than that in these small bowel obstruction pictures. Also on that note, the diameter of the large bowel should be no more than 6 centimeters, and the diameter of the cecum should be no more than 9 centimeters. So that I remember that just by 3, 6, 9. Okay. The next pathology we've got is, you can see something not looking quite normal here. Does anyone know what it is? So this is a large bowel obstruction, and you can see in this that the haustra are visible, running halfway across, whereas the valvae convenientes run the complete diameter. Okay. This next image it's not very clear, but if you can slightly see, this is a coffee bean sign, which is classic of a sigmoid volvulus. Again, this is a spot diagnosis. Sometimes the coffee bean sign is a lot more obvious, but I've just given you this one as it's because it's quite tricky. Just as a side note, when you are presenting an X-ray, it's important to go through it in that systematic approach. Okay, moving on to the next. So does anyone know what this is, or just have a think what we can see? So you can see quite a dilated colon here. It looks to be probably greater than 6 centimeters. And you can see some of the haustra. But then you've got this straight sort of colon here, which would be the sigmoid area. And this is the classic toxic megacolon. So you've got this lead pipe colon. This is a lead pipe colon sign. Okay. So as we were talking about obstructions, in particular like large bowel and small bowel obstructions, does anyone know how you may diagnose a perforation if this progresses further?
So would you do like an erect chest X-ray and you'll see air under the diaphragm?
Absolutely, that's perfect, yeah. Sometimes on CT, this is called Wriggler's sign, okay. But yeah, erect chest X-ray, air under the diaphragm, perfect. Okay, and that's the toxic megacolon. So just some final tips to finish off with. It's better to start now with your finals revision, but do little and often. It's really important to watch the lectures, revise the CBLs and the CCTs, certainly because technically the med school have to examine you on the content that's taught. It's important to know sort of some basic things that are just factual, and the best way to probably know this is by doing making some flashcards. So make sure you know the red flags, symptoms, make sure you know the 2-week wait rules and referral guidelines. Sort of simple things like that will pick up some marks. Make sure you do some practice questions. So you might like PassMed or various other question banks like QuesMed, pretty good, Capsule, or the various ones from the med school. I quite like this book in terms of OSCE practice. I'd recommend forming a group and trying to do some group revision OSCE style, maybe come up with some stations or use this book for some scenarios. And finally, it's obviously very important to take a break and not work too hard. It's all about little and often, basically. And it's surprising how much you do pick up on placement. Okay. So thank you so much for listening, everyone. If you're able to scan this QR code, that would be great, just to give some feedbacks in order to make this talk better in the future. My email address is at the bottom here. If you've got any questions, feel free to email me. So thank you.
Perfect, thank you. Thanks, Lauren.
Thank you. Thank you.
Yeah, that was really useful. Thank you.
No probs.
Perfect. I'll stop.